Greetings from India. You are listening to the Businesstalk podcast. I'm Deepak, your host for today's episode. We are honored to welcome Dr. K. M. Venkat Narayan, Executive Director of the Emory Global Diabetes Research Center and the Ruth and O. C. Hubert Professor of Global Health and Epidemiology at Emory University's Rollins School of Public Health as our distinguished guest on today's podcast episode. Dr. Narayan also holds the position of Professor of Medicine and Endocrinology at Emory University School of Medicine. A globally recognized leader in diabetes research and a member of the National Academy of Medicine, Dr. Narayan has shaped policy and practice through extensive work on diabetes and non-communicable disease. His career spans major international epidemiological studies, randomized trials, and policy research with a strong emphasis on translating science into public health impact. Currently, his research explores pancreatic beta cell biology and the unique pattern of type 2 diabetes across Asian, African, Native American, and other developing populations worldwide. With over 550 publications and more than 185,000 citations, Dr. Narayan's scholarship reflects his pioneering contribution to advancing global diabetes science, policy, and practice. Dr. K. M. Venkat Narayan was honored with the 2025 Distinguished International Service in the Cause of Diabetes Award for his outstanding contributions to global diabetes research and care. In today's episode, Dr. Venkat Narayan discusses his healthcare research from bench to community, translating diabetes research into global health impact. So, without further delay, let's welcome Dr. Venkat Narayan to the podcast. Dr.
Thank
Narayan,
you.
thank you for graciously accepting our invitation. It is an honor and privilege to have you with us today.
Thank you, Deepak. It's a pleasure talking to you.
Professor, can you start by explaining what translational research in diabetes entails and why it's crucial for bridging the gap between laboratory discoveries and community health outcomes?
So basically, when we say translational research, what we really mean is all the discoveries that are happening at the bench, all the trials and epidemiological studies that are being done, are they getting translated both to the bedside so that clinical care can be improved, and are they being translated to the community so that public health, the health of the population can be improved? So that's what translational research really is. And the reason it is very important is two things. Number one, when you think of research, you can think of research in two dimensions. Dimension one would be research for the sake of generating knowledge. That is, in there's probably no application directly connected. I mean, some of the great discoveries, like Einstein's equation, for example, he didn't set out wanting to do anything with it. It just happened, but over a period of time, it led to a number of things. So that way, that kind of basic discovery research is also important. But more importantly, when we think of research, we want to make sure that research impacts the patient, it impacts the community. And studies have shown that the lag between research and its application can be as long as 17 or 20 years. So translational research is a way of speeding that transformation from research into practice and public health.
Professor, what are some of the examples from your work where a lab-based finding directly lead to a tangible intervention in a community settings?
Yeah, you can think about it. Several things. Number one, let's take some simple examples. I mean, in the field of diabetes, one of the early genes that were identified was what's called, monogenic diabetes, single gene diabetes. That's a very small percentage, about 2% of all diabetes, but those are specifically informed how to manage those patients with those monogenic variety, for example. And then increasingly now we are developing scores of polygenic. So taking a person, finding out all the different genes that they may have, and then using that to predict their prognosis or the different types of diabetes they might develop in their future. So that is another kind of translational research, etc. And when you think about it, almost all the tests that we use for diabetes, diagnosing diabetes, like your fasting glucose, your 2-hour glucose, your hemoglobin A1C, all of these originated in laboratories. All of these originated in chemistry. So I think that is where some of the connections happen. And then you can then go beyond that and say there have been a number of trials in the last 20, 25 years on better ways of treating diabetes through different medications, better way of managing blood pressure, better ways of managing lipids in people with diabetes, better way of managing and protecting the kidney, for example. Many of these trials, are the whole body of trials here. So taking the results of those trials and improving the quality of care and improving patient outcomes. Those are also some examples of translational research.
How do challenges in low and middle income countries shape the way diabetes interventions are designed and implemented compared to high income countries?
Yeah, this is a very good question. But, I've been working in the field of global health now for almost nearly 20 years. Prior to that, all my work was in the United States. There's two ways of looking at this question. One is, are there challenges that are bigger in low and middle income countries, or might there be opportunities that are greater for innovation in low and middle income countries? I mean, I want to frame the question slightly differently here. And the reason I think there are opportunities is because in low and middle income countries, there are two things. Number one, there's a large mass, the populations are large, and the healthcare delivery infrastructure is small, and the size of the workforce is also small. So the question is, how can you scale interventions and make them affordable and make them accessible? So in that sense, it becomes a possibility of actually inventing technologies that are affordable, that are scalable to large volumes of people. I mean, like, for example, an average physician in the United States probably might see 5, 6, 7, 10 patients a day, whereas an average person in India, for example, sees many times over that. And, so similarly, in terms of even in the COVID vaccine, for example, we noticed after the Delta wave, India managed to vaccinate hundreds of millions very rapidly. So how did they do that? So I think, and similarly, can we use technology? Can we use artificial intelligence to better deliver care? Can we use telemedicine to better deliver care? Can we use mobile technology to better deliver care? Can we come up with diagnostics that are cheaper? I mean, classic examples here would be the vaccines, for example. India today supplies 60 to 70% of the global vaccines and have made it affordable. Can we do the same thing with new generation drugs? Like in the area of diabetes, there are something like 13 classes of drugs. And the newer drugs are almost unaffordable, even in high income countries. So can countries like India, using the wonderful chemistry they have, using the wonderful enterprise they have, make these drugs affordable to large numbers of people in India and worldwide? I think these are some of the interesting questions. But beside that, of course, there are challenges. The biggest challenges, I think, number one, is the infrastructure. The quality of good diabetes care is not just about how good the diabetes doctor is. It is about the good team, the right team of multidisciplinary team, and the data infrastructure, electronic medical record infrastructure, and the community support structures. And it's organized care. An average person with diabetes probably needs 7 to 10 different drugs a day and has to manage that lifelong, has to manage his diet, his physical activity, needs to get his eyes checked every year, needs to get his blood pressure managed, needs to get his kidneys checked. So organization of care becomes extremely important. And this is where a lot of medicine can learn from management science and from organizational science. I think that, and those are some of the opportunities. Building the system would be a challenge. And I think that is something that countries like India need to focus on larger scale.
Professor, what factors determine whether a successful pilot or clinical trial can be scaled to a wider population effectively?
Yeah, I think this is why, in the past, we used to think about these things in a very linear way. We would do trials to demonstrate proof of principle that something works. And then we would think in terms of can this be applied in real life? And then we will think in terms of can it be scaled up? But some of the lessons we learned in the last few years, particularly with COVID, etc., is many of these things have to be done simultaneously. For example, when you're designing a trial with a new drug, simultaneously be thinking about, yes, in a tightly controlled laboratory kind of situation, this might work, but in free living humans, how can I make it work? or will it work as effectively? And then to scale it up, what kind of partners do I need to bring in? So if we can think about it, in parallel, then the translation becomes more rapid and more effective.
Dr. Narayan, how important is community involvement in translational research, and what strategies have proven effective in ensuring local adoption and sustainability?
Yeah, I mean, in a word, community involvement is extremely important. But I would say appropriate community involvement is important because I think the field, if you think of the field of community involvement and the science that has gone into it, there was a time when communities are never involved. And then there is also the opposite camp of it almost becoming a dogma that you need to always involve the community. And the question is, what's the right and appropriate way of doing it? Like, for example, if you're designing a new trial with a new drug or designing a research study, then the community involvement possibly isn't in getting feedback into will there be acceptance for this research in the community? If not, how do I make it acceptable? Or can you help us, interpret both the benefits of the research and the side effects of the research to the community members? That could be one level of involvement. So the champions in the community. The second would be, suppose we want to translate, let's say, diabetes prevention into the community. The question is, the reason we involve community there is because the community members are the best to tell you, what resources are available in the community, what will be acceptable to the members of the community, what will not be acceptable to that particular culture. So getting that sort of input becomes extremely important. And finally, if you want any local action, and it doesn't matter which country you're living in, the political local action to take some science into policy always requires the voice of the community. And I think for all of these reasons, the community needs to definitely be involved. But depending on what stage you are in your research or in your public health application, the type of involvement becomes very different. And the type of community that you involve becomes different. There are certain players who are very good at one thing, and there are certain players who are good at the other thing.
In your experience, how have digital health tools, mobile apps, or AI enhanced the translation of research into real-world diabetes interventions?
Oh, in many ways. And in fact, I think this is where I think the greatest opportunity lies to be able to translate research into better health and health outcomes for populations. For example, let's take telemedicine. In a country like India, where you have a lot of rural, urban centers with specialists, but distant rural areas without specialists, telemedicine integrated with local primary care teams in rural areas would be a very effective way of delivering care. And I think that is, digital health becomes important there. And then similarly, mobile health. Every individual, I think, now almost everybody has an iPhone. So can we use the iPhone more as a tool to advance health? You can do all kinds of things with the iPhone. You can have it can measure a lot of your vital signs, your blood pressure, your stress levels, your sleep levels, your physical activity levels. You can even measure what kind of diet a person is, eating, etc. And can you combine that with AI to provide, better counseling, education, to the patient, number one. And secondly, like I said, in a disease like diabetes, there's lots of, you need to comply with so many different drugs. You need to comply with so many different visits to the doctors. Can the mobile technology be used as a reminder, both to the patient, in terms of, you need to increase your blood pressure medication, you need to do that. You've had this gulab jamun, can you go for a walk, for example, that kind of thing. And more importantly, also for the physician. When you go to see your doctor, if you're lucky, you might get 5 minutes, 8 minutes with the doctor. So in that 8 minutes, the doctor has to do a number of things. So if can the iPhone or a reminder system be used to remind the doctors to what is the most important thing for that particular patient? And then we have found repeatedly that for chronic diseases like diabetes, cardiovascular diseases, asthma, electronic medical records are extremely important because they allow you to monitor care and to monitor quality of care of for the individual and for teams of physicians and healthcare providers, and provides you the opportunity to integrate care with a feedback loop of audit and feedback. So in all of these areas, and going forward, AI is going to play a huge role in the area of diagnosis. Like, for example, there are AI models now by taking a picture of your eye and using the blood vessel mapping of the eye along with AI, we can predict what your risk of diabetes is, what your risk of cardiovascular disease is, what your risk of dementia is. So those kind of diagnostics and predictions are going to improve with AI. And similarly, AI might be a good, would also it will also help us to inform us as to what kind of therapy will be suitable for this particular individual. And finally, I think AI might have a scope for delivery of care. Like I said, if you can combine AI and data and community workers, maybe there are delivery models where a lot of our primary care can be done sitting at home. You don't have to go to a hospital for that. That might be the future of technology.
Professor, what metrics or indicators do you use to evaluate whether a research-based intervention is actually improving health outcomes in the community?
Yeah, I think we can do it at several levels. I mean, one way of thinking about it is it's structure, process, and outcomes. At the level of the structure, you can think in terms of, as a result of this, has better infrastructure developed? Are we able to, create better workforce? Are you able to create better databases in electronic medical record systems? Okay. And at the level of the process, is your intervention acceptable to the people? Are they ready to is the compliance with medication higher? Are people changing their health behaviors? Like, are they exercising more? Are they, changing their diet more? Are they sleeping better? Those kind of things. And in terms of outcomes at the level of the individuals, is somebody controlling his glucose better, blood pressure better, lipids better, giving up smoking? And then at the level of the population, are you seeing declines in mortality rates in people with diabetes? Are you seeing declines in complication rates in people with diabetes? Are you seeing declines in what's happening to the cost of healthcare? For example, now in the last 15 years, in many high-income countries, we are actually seeing a decline in mortality rates and in complication rates in people with diabetes. That is not happening at the population level in many low and middle income countries. And there's no reason why it cannot happen. It can easily be done. It's a matter of translating research into practice and creating the organizational structure to make it happen.
What are the most common roadblocks you encounter when moving from bench research to community level implementation, and how do you navigate them?
Yeah, there are a number of things. Firstly, of course, funding for research and funding is one important area. But more importantly, as you go from basic bench research more into clinical research and into the public health kind of domain, it becomes more and more interdisciplinary. Like, for example, we now have started using a term called convergent science, where to have impact and to solve some of the big issues of today, whether it's chronic diseases or it's climate change or it's poverty or whatever it is, it requires convergence of basic sciences, of sciences, of medicine, of humanities and engineering. You'd be surprised that a lot of engineering solutions are possible for health challenges. And that's why, for example, IIT Kanpur has started a medical school. IIT Madras in Chennai has started a Department of Health and Medicine, of Health and Engineering. So there is a lot of interest. So I think bringing together the various disciplines, that would be the second challenge. And the third challenge is really about changing how we train people for interdisciplinary science and attracting people into research. I mean, for example, India contributes to 23 to 25% of the global burden of diabetes, but research in Indian population only contributes to less than 1% of diabetes research worldwide. So that is a huge gap. And we have to overcome that gap, because unless you overcome the gap, you're going to do, the research that is done in high income countries may not be contextually relevant. And that's why a country like India needs to invest in research, both to improve health and also it's better for the economy. Research is extremely good for the economy. So as India goes up the ladder from low middle income to middle income, it's going to require huge investments in research to achieve that economic progression.
Professor, I would like to conclude this episode with one last question. Looking ahead, Both emerging research or innovation give you hope for reducing the global burden of diabetes, particularly in resource-limited settings.
Yeah, in fact, a number of things. I mean, clearly now, on the one hand, we have a lot of excellent evidence that that lifestyle interventions effectively implemented can delay the onset of diabetes in substantially. Number one. Secondly, in terms of treatment and management of diabetes, there's a lot of therapeutics, a lot of diagnostics available currently that can easily help you control your glucose, blood pressure, lipids, prevent eye complications, etc. So the science for preventing a lot of diabetes and the science for preventing a lot of diabetes complications and improving quality of life is very high. And we have the tools such as the decision support tools, the community health worker training tools, or the quality improvement tools. So implementing them rapidly, like has happened in high income countries, is something that's low hanging fruit that can be done and in 10 years, you can start seeing major improvements in terms of reductions in mortality and reductions in complications in people with diabetes. Looking forward, there are a number of things that give me a lot of hope. Firstly, like I said, there is a hugely new levels of therapeutics. The GLP-1, for example, we did an analysis that is the GLP drugs, which are extremely expensive now, are affordable and accessible to all the people worldwide who qualify for it. In other words, people with diabetes, people with certain levels of obesity per the guidelines. Our model suggests that you can save worldwide in a 5-year period 37.5 million deaths, and you can halve the obesity levels worldwide, which means 500 million fewer people with obesity. So that those kind of powerful interventions are available to us, and those need to be implemented. And the problem is lowering the cost of those drugs is going to require tremendous collaboration, not across multiple sectors. You need industry, you need chemistry, you need entrepreneurs, you need government, you need all of them collaborating to do that. I think so that would be the number two. And thirdly, we are beginning to realize, thanks to advances in molecular biology and advances in artificial intelligence, we are beginning to realize that diabetes is not one disease, it's probably multiple diseases, and each person's diabetes might be very different from somebody else's. I mean, the way you respond to food might be very different from the way I respond to a certain food. So understanding, now we have the tools to understand all this. So I think the future is going to be more personalized, more individualized, more precision diabetes and prevention. So I think for all those reasons, we are at a very exciting time in terms of science. And I think science, if employed, can make a huge difference to the health of individuals, to the health of populations, and to economies. And I would mention economies because if you take India, 50% of Indians are below the age of 30, or it's a very young population. And unfortunately, diseases like diabetes and heart disease are affecting Indians at younger ages. So if a 30-year-old person in India develops diabetes, heart disease, you're taking away years of production and you're making those people. So there are data suggesting a lot of people are one illness away from poverty. So a person who's doing very well develops a heart attack or a kidney disease can easily go into poverty. So I think that's why I think addressing diabetes is important. But this also requires social actions, like you need social networks, health insurance models so that people have protections. All of these are going to be important.
Listeners, as we wrap up today's conversation, it's clear that translating diabetes research from the lab to real-world communities is both a challenge and an opportunity. Dr. Narayan's work reminds us that impactful science doesn't end at discovery, it begins when it reaches the people who need it most. From scalable interventions in low and middle income countries to shaping policies and engaging communities, the journey from bench to community is a complex but ultimately transformative. Thank you, Dr. Venkat Narayan, for sharing your insights, experiences, and vision for a future where research drives measurable health impact. Thank you so much.
Thank you very much, Deepak, and thank you for doing this. These podcasts that you're doing is of a great value and contribution to the world, and please do it.
Thank you.
Thank you.